All right, today we're doing something a little different. We're going to step inside one of the most intense situations in all of medicine, the consultant level surgical viva exam. We're going to run through a simulated trauma case, minute by agonizing minute, to really break down the kind of critical thinking you need when every single second counts. So, let's get started.
So I want you to picture this. You're the candidate. The room is dead quiet, that clock on the wall is ticking way too loud, and your entire career has led you to this very moment. The examiner looks you right in the eye and begins.
And there it is, the first challenge. You don't have a lot of information, but you have the most important phrase: high energy mechanism. That right there should set off alarm bells for potential injuries everywhere. Head, chest, abdomen, pelvis, the whole 9 yards. The clock is officially ticking. Your preparation has to be perfect.
Okay, first thing I'm doing is activating a full level 1 trauma team. That high energy mechanism demands it. I'm going to brief the entire team on what's coming, and I'll be clear. Anticipate major bleeding and a very difficult airway. In the trauma bay itself, I want the surgical airway kit opened and ready, 2 large bore IVs prepped, and a rapid infuser primed with warmed blood. I'll get my PPE on, and then, this is key, I'll assign very clear roles: someone on airway, someone on IV access, someone for chest procedures, and a dedicated scribe. I want a calm, organized room before that patient ever hits the door.
The doors burst open, the patient is here, and immediately you have your first crisis: an obstructed airway. Gurgling means fluid, probably blood. Unconscious means he can't protect his own airway. This is the first life threat, and you have to solve it. Now, what do? My immediate priority is A for airway, and you have to do it with simultaneous cervical spine precautions. That gurgling sound is a 5-alarm fire. It tells me there's a physical blockage. We are officially starting the primary survey, strictly following the Advanced Trauma Life Support, or ATLS, protocol. Okay, first I'm going to have a team member maintain manual inline stabilization of the neck while I perform a jaw thrust. No head tilt chin lift here. At the same time, I'm yelling for suction to clear out whatever is in his mouth. Look, he's unconscious, GCS of 3, with an unprotected airway. There's no debate. He needs a definitive airway. I'm announcing to the room, we are performing a rapid sequence intubation, and I'm asking the team to draw up the drugs and prep the equipment. So you try to intubate. You get the laryngoscope in, but you can't see a thing. It's all blood and swollen tissue. You can't see the cords. You are now officially in a can't intubate, can't oxygenate nightmare scenario. What is your next life-saving move? This is a failed airway. There's no time to waste. I have to establish a surgical airway immediately. The procedure is a cricothyroidotomy. I'm making a vertical incision over the cricothyroid membrane, using my finger to bluntly dissect and find that membrane, then a horizontal stab through the membrane itself. Then I'll slide a size 6.0 tube end to secure the airway. Okay, the airway is secure. We can all take half a breath. Now I'm moving immediately to B for breathing. My job now is to find and fix any life-threatening injuries in the chest. I'm assessing the chest, and I am hunting for killers. Top of my list, attention pneumothorax. That's when you get a one-way air leak into the chest that not only collapses a lung, but it actually pushes on the heart and can cause a cardiac arrest. I'm looking for the classic signs. Is the trachea pushed over to one side? And I'm listening. Are the breath sounds totally gone on one side? Your exam finds exactly that. No breath sounds on the right, and the trachea is deviated to the left. The patient's blood pressure is dropping. You've just made the clinical diagnosis of a right-sided tension pneumothorax. What do you do right this second? This is a clinical diagnosis. You cannot wait for an X-ray. I'm immediately performing a needle decompression with a big 14-gauge cannula in the 5th intercostal space, mid-axillary line. You should hear a hiss of air. Now that just converts the tension pneumothorax to a simple one. It buys you time. The definitive treatment, which I'll do immediately after, is a formal chest tube or tube thoracostomy in the same spot. So you place the chest tube, and the second it's in, you get a massive gush of blood into the chamber, 1,600 milliliters. What does this mean, and what are the implications? An initial output of over 1,500 mLs of blood is the textbook definition of a massive hemothorax. That is a huge red flag. It is an absolute, non-negotiable indication for surgery. My patient is in class 4 hemorrhagic shock, and my focus instantly pivots to C for circulation. I need to stop the bleeding and resuscitate like crazy to get him to the operating room alive. My team already has 2 large bore IVs going. I've already hit the big red button to activate our hospital's massive transfusion protocol. I need blood products, packed red cells, plasma, and platelets in a balanced 1-to-1-to-1 ratio, and I need them now. I'm also giving tranexamic acid, or TXA, because we're well within that 3-hour window from the time of injury. This isn't about getting his blood pressure back to normal. This is damage control resuscitation.
But despite everything you're doing, the patient crashes. His blood pressure drops to 60, and then you can't feel a carotid pulse anymore. He is in traumatic cardiac arrest. What are you thinking? What is the final, most drastic option you have? This patient has arrested from blunt trauma, and we witnessed him lose his pulse right here in the emergency department. That means he meets the very strict criteria for a resuscitative thoracotomy. I need to crack his chest right here, right now. The goals are simple. Open the chest to relieve any cardiac tamponade, get my hand in there to control the bleeding, cross-clamp the aorta to force blood to the brain and heart, and start internal cardiac massage. This is an absolute last-ditch effort to save his life. And somehow, it works. You perform the thoracotomy, you get control of the hemorrhage, and you get a pulse back. He's being rushed to the operating room, but in this fragile moment of stability, you have to finish the primary survey. What is D? D stands for disability. It's a quick neurological check. And our main tool here is the Glasgow Coma Scale, or GCS. It's a score based on eye, verbal, and motor responses. This patient was unconscious on arrival, so his GCS was 3. The rule is simple. A GCS of 8 or less means you have a severe head injury, and it is an absolute indication to intubate. I'm also checking his pupils for size and reaction, looking for any sign of a brain bleed. So after the patient is stabilized, a CT scan shows this, an epidural hematoma. The classic finding, as you can see, is this biconvex or lens-shaped pool of blood. And here's the key diagnostic clue. It doesn't cross the suture lines of the skull. That's because the dura, the tough outer layer covering the brain, is tacked down really tightly at those seams. This shape almost always points to an arterial bleed, which is a major neurosurgical emergency. So the primary survey is complete. All the immediate life threats have been managed. The patient is stable for now. What comes next? How do you complete the full assessment of this patient? After the primary survey and the initial resuscitation, we can finally move on to the secondary survey. This is where we do a careful, systematic, head-to-toe exam and review all the imaging to find every single injury. A huge part of this is getting the ample history from paramedics or family. We need to know about allergies, medications, especially blood thinners, which would be a game changer, past medical history, time of his last meal, and the specific events of the trauma. Okay, let's pause the simulation there. The candidate has navigated an absolute minefield of a case through the primary survey. Now let's debrief. What were the critical, high-yield takeaways from that whole scenario? Look, what this case really hammers home are the critical decision points. First, the ABCDE algorithm isn't a one-and-done checklist, it's a loop. Anytime the patient gets worse, you go right back to A. Second, the decision to cut the neck for an airway has to happen without hesitation when intubation fails. Third, knowing that 1,500 milliliters from a chest tube is your trigger for surgery, that removes all the guesswork. And finally, that resuscitative thoracotomy is a Hail Mary, and you have to know the exact indications cold. In trauma, survival often comes down to knowing these hard lines and acting on them instantly. This whole simulation really highlights the intense cognitive pressure of trauma care. Every single decision matters, and the patient's condition can turn on a dime. We've just walked through one really tough scenario, but the next one is always different. And that leaves us with the real question, doesn't it? How do we prepare ourselves to be ready every single time?